Thank you, Kalpesh and the team. I am Prashant Agrawal, General Manager Marketing. On the behalf of Adley Oncology, I would like to thank Dr. M.B. Agrawal, sir, for giving us this opportunity again and again. And now I would like to welcome Dr. Talha Badar. And also I would like to welcome our eminent speaker and discussants. Now I have just a small presentation. I just go through this about the Adley Oncology. Adley Oncology is more than 35 years of experience. It is one of the fastest growing oncology company in India. Now, recently it has been recognized by the Forbes Asia. And this is the testament of our research and development, our operational efficiency, and our growth mindset. Now, I can tell you we are available in more than 46 countries. We have an approval for most of the international accreditations. For example, EAU, Anvisa, PICS, etc. Very soon we are going to get the EU approval, European approval also. We are focusing on the patient-centric approach. Our main focus is patients. And that's why we are continuously developing the new NDDS formulations. We are investing heavily on R&D. We are the first to launch the few of the drugs like betatinib, like Kylonib. And we are very soon going to launch pomalidomide as well. Not only this, we are working on the supportive care continuously. So with this, I can say the organization is looking for the patients. We are providing the cost-effective medicines. Our supply chain is very strong. It is available in more than 80% hospitals, corporate and the government hospitals. And I would like to once again thank you for all of you. So you are coming to this webinar and attending this webinar. Thank you, and over to MB Agrawal. So.
Thank you, Prashant, for those kind words and starting this webinar. And good evening to one and all from India, and good afternoon, good morning for those who are from the rest of the world. Today, our guest speaker is once again Dr. Talha Badar from Mayo Clinic Cancer Center, Florida. And he's going to speak to us on risk stratification and management of lower risk myelodysplastic syndrome. This webinar, as you know, is brought to you by Mumbai Hematology Group, supported by Adley and managed by Perfect Square. I thank Mr. Ashutosh Shukla and their team from Adley, Yash Kalpesh and their team from Perfect Square, Executive Committee of Mumbai Hematology Group. Most importantly, our guest speaker of the day, Dr. Talha Badar from Florida, who is giving today the 5th webinar to us during last 4 years. All our discussants who are themselves eminent hematologists or medical oncologists, and you participants for sparing your Saturday evening, afternoon, or morning. Tomorrow morning, we will be discussing relapsed refractory large B-cell lymphoma with our guest speaker from Poland. Our discussants today include some important personalities. Dr. Akanksha Garg from Zydus Hospital, Ahmedabad. Dr. Alka Khadwal from PGI Chandigarh. Dr. Amit Khurana, of course, from Surat, and he has been instrumental in helping me in conducting a large number of these webinars. After the pandemic got over, it was becoming extremely difficult to manage this, and he has been my left and right hand. Dr. Ankit Rayani from Ahmedabad. Dr. Deepanjan Haldar from Jupiter Hospital, Mumbai. Dr. Gaurav Dikshit from Gurgaon. Dr. Hasmukh Balar from Surat. Dr. Mukesh Sharma from Raipur. Dr. Nilesh Vasekar from Nashik. Dr. Nishad Dhakate from Nagpur, Professor Dr. Colonel Prakash Chitalkar from Sir Aurobindo Institute of Medical Sciences, Indore, Colonel Dr. Rajan Kapoor from RNR, Delhi, Dr. Rajiv Gupta from Government Medical College, Jammu, Dr. Rajiv Sendal from Indira Gandhi Medical College, Shimla, Dr. Suneet Lokwani from Kokilabin Dhirubhai Ambani Hospital, Indore. And now, to complete the formalities, all of you know Dr. Bala so well. He has spoken to us so many times, and we have enjoyed and learned so much from him that I don't think he needs an introduction, but this is a formality which I must complete. He is a physician scientist with the division of hematology and oncology. He's assistant professor at the Mayo Clinic, Florida, with special interest in the high-risk acute leukemia and other myeloid disorders. He's leading the consortium on myeloid malignancies and neoplastic diseases, where they are conducting retrospective and prospective studies. He has conducted several studies evaluating outcomes of TP53 mutated AML, which, as you know, is one of the very high-risk leukemia and is a great unmet need. Through his work, he was able to highlight the genomic landscape, Hematologica 2024, racial disparities, Cancer 2023, an impact of novel therapies and transplants on outcome of TP53 mutated AML, American Journal of Hematology 22, and Leukemia 23. Observing very poor outcome of patients with high-risk myeloid neoplasia spurred his interest on to develop innovative clinical trials for affected patients. He did observational and correlative studies evaluating clinical outcomes of myeloid neoplasms associated with DDX41 mutated germline predisposition syndrome. He observed lack of typical MN-associated somatic mutations and age-related clonal hematopoiesis in DDX41 mutated MN, ASH 2023, suggesting need for better understanding of the mechanism of disease progression in DDX41 mutated MN. He's currently conducting single-cell sequencing and functional studies to better understand leukemogenesis in DDX41 mutated GPS with the hope to detect therapeutic vulnerability that could lead to clinical trial opportunities. Recently, he has started working on clinical trials concepts in collaboration with NCI Experimental Therapeutics Clinical Trial Network, focusing on myeloid disease with high unmet needs. And as I mentioned, today he's going to speak to us on risk stratification management of lower risk MDS. Well, thank you so much. And I will stop sharing and hand over the dais to him.
Thank you so much, Dr. Agarwal, for the kind introduction. And it's my pleasure and honor to be working with your eminent group. And today we'll discuss about risk stratification MDS and focusing on our discussion on low risk MDS, essentially. If you allow me, I would like to share my screen. Is it readable for you guys?
Yes.
Viewable?
Yes.
Okay, good. So should we start now, Dr. Agarwal?
Yes, please.
Okay. So low risk MDS, how should I? Yeah. As you all know, the background, the MDS is a spectrum with heterogeneous molecular features and with variable outcome, and characterized by ineffective erythematopoiesis, and risk of progression to AML is dependent on the risk type of MDS. Commonly in US, it's seen in elderly patients, and the median age these days, most current CA data suggests that it occurs in 75 and older individual. And it's one of the rare diseases when you talk about cancer in general. But when it happens, it has some serious consequences that need to be addressed. So next few slides, I will go over the evolution of the prognostication we have done over the years, over the last 2 decades, when it comes to MDS. Starting with classification predominantly based on morphological features, and divide them, as you can see here, by various classification system, expanding from some common molecular features such as deletion 5q, but mainly morphological features looking at ring sideroblast and multi-lineage dysplasia. But it has evolved over time. And with the passage of time, we start incorporating some more factors that could predict outcome of this group of patients. So as you all know, this is the cytogenetic classification, which is still incorporated in the most recent IPSS-M stratification model, which I'll be discussing it shortly and briefly. So where you can see very good, good, poor, and very poor chromosomal markers impacting the outcome significantly. As you can see here, median survival at the time of reported of this paper was around 6 months for very complex cytogenetics associated with MDS. These were the tools which have been used, IPSS and IPSS-R in the middle. IPSS-R divides into 5 risk groups: very low, low, intermediate, 1, 2, and high. IPSS-R is very feasible, globally available. Until now, whatever approved drugs we have seen over the last few years for low risk MDS, the clinical trial parameters or the eligibility criteria incorporated IPSS-R is the risk stratification tool to seek eligibility of the patients who are enrolled in those studies, which lead to FDA approval. We'll discuss in coming slides. However, when I say that IPSS-R has been widely used and feasible and economical, and it has been used in pivotal clinical trials up till now, and it has been gold standard, it has some limitation. It doesn't incorporate the somatic mutation landscape, and among 50% of the time, under stage MDS, that could be critical in how we manage these patients, and potentially when we aim to potentially cure subset of patients who are eligible to receive intensive chemotherapy, such as bone marrow transplant. So before the IPSS-M got incorporated a few years ago, and now more and more people are utilizing that strategy to risk stratify and to look for therapies for MDS patients. Prior to that, there were studies that showed patients with low risk disease or intermediate risk disease having certain molecular characteristics had a variable outcome, where you can see the EZH2, AXL1, p53 mutation are independently associated with shorter overall survival for low risk patients having high risk molecular features. And most recently, as you can see here, the IPSS-M got established. A tremendous amount of work was done utilizing a 31 gene panel, which incorporated and significantly risk stratify MDS patients into several risk groups, where those with splicing function mutations such as SF3B1, which also have a therapeutic indication, tends to have a favorable outcome, whereas those with P53 or AXL1 tends to have a inferior outcome. Having said that, it's a newer tool. It better stratify MDS patients. It may help us in undefined therapeutic targets in very small subset of patients we'll discuss in future slides. But it's not feasible across the globe because the genomic sequencing techniques at some places still it's very time consuming. On the other hand, it's also very expensive. And places where the healthcare is funded by the state or the government, it would be harder for them to adopt this technology. When I talk about this, mainly in Europe and some other resource restricted countries where patients pay their healthcare out of their pocket, it may cost significant amount of money and may not be feasible, applicable across the board. But this is now the new standard how you stratify MDS patients, as I told you, with prognostic and therapeutic implications. Then this slide basically based on what we have learned about MDS over the years, based on we know about the pathobiology of this disease, most recent WHO and ICC classification in 2022 introduced several new subtypes of MDS, which has prognostic value. Among the first one is MDS with fibrosis. As you all know, there's a category called MDS and MPN, overlap syndrome, where you see certain features of MDS and certain features of myeloproliferative neoplasm, such as seeing a anemia with some dysplastic changes in ineffective erythropoiesis maturation. On the same time, you will see more proliferative phenotypes such as megakaryocytic hyperplasia. These patients generally run a normal chromosome but have multiple somatic mutation. But there is another category called MDS with fibrosis. This patient clinical practice you might have across, that these are hard to treat patient population who present with significant cytopenias and doesn't respond well to growth factor support such as ESA and others to improve anemia, and continues to require high transfusion needs, leading to secondary hemosiderosis and dismal outcome. Apart from that, as I mentioned, the IPSS-M category, which highlighted the SF3B1 mutation, which tends to have a favorable outcome, and these patients do respond to one of the newer approved agent, which helps in improving the transfusion needs and improving hemoglobin, called SF3B1. And as you all know, P53 mutated MDS and AML, these are the distinct subcategory which unfortunately continues to do poorly, and conventional therapies doesn't work for this subgroup of patients, and we all are struggling to find better way how to manage this group of patients, which is now classified as distinct category. There's another category called MDS AML, where you see a more than 10% blast count in the bone marrow, the myeloblast, by flow as well as immunohistochemistry. But these patients doesn't have classical MDS defining or AML defining molecular or chromosomal alterations. But this is a high risk group, and now there's a focus on include these patients in high risk MDS and AML trials because they tends to have a comparable outcome to their high risk MDS and AML counterpart. So that is another introduction in the most recent ICC 2022 classification. So I will initiate my discussion with sharing a case with you, which is one of my clinic patients. And then based on this clinical scenario, I will discuss some clinical trials recently, which leads to FDA approval, and take it from there. So this is a 61-year-old lady with transfusion-dependent anemia, and on presentation had a hemoglobin of 7, white cell count 4.7, ANC 2.6, and platelet 325. Erythropoietin level 55, and bone marrow biopsy revealed erythroid hyperplasia with ring sideroblasts more than 15%. The myeloid blasts were not increased, chromosomes were diploid, and genomic sequencing data revealed DNMT3A and SF3B1 mutation. When we incorporate IPSS-R, she was found to have a low-risk disease. So how would you manage this patient, 61-year-old with MDS, ring sideroblast, having high transfusion needs in predominantly anemic with low-risk MDS? Would you offer lenalidomide, luspatercept, ESA, or a newer agent, imetelstat, a telomerase inhibitor? So initially, I treated this in patient with erythropoietin-stimulating agent, and for some time, I did see transfusion independence as well as decrease improvement in hemoglobin. However, the response were not long lasting, unfortunately, and after 9 months, she started to have drop in hemoglobin with going into 7th, although maintained white cell and platelet count. This time, after 9 months of therapy with ESA, the EPO level is more than 500. In this scenario, how one should treat this individual with lenalidomide, luspatercept, imetelstat, or moving to hypomycin agent therapy. That may be a more realistic scenario in resource-restricted countries where getting Reblozyl, luspatercept, imetelstat may be out of reach of patients who are paying out of their pocket. So we'll discuss a couple of trials of luspatercept, which leads to this FDA label over the last couple of years or so. Luspatercept is a transforming growth factor beta fusion trap protein, which neutralizes the TGF beta and restores the erythropoiesis, which is impaired predominantly among individuals with MDS, especially those with low risk MDS. After initial phase 1b study, which showed effectiveness and tolerability, the phase 3 trial was conducted called Medalist trial, in which patients with ring sideroblast, IPSS are very low into intermediate risk MDS, transfusion dependent, and refractory to or intolerant to ACE randomized to 2:1. Around 300 patients were enrolled and randomized, and the primary endpoint of this trial, it's important to know, was not improvement in hemoglobin, but transfusion independence. And the second endpoint was achieving transfusion independence for 8 weeks or longer. So the primary endpoint of this trial was met, as well as endpoint, as you can see on the bar chart on the left side of mine, where the transfusion independence for 8 weeks or longer was achieved in more than around 38% of patients. And around 20% of patients maintained this for 12 weeks or longer. In terms of adverse events, generally it's well-tolerated drug. In elderly individuals, I've seen complaints of diarrhea and dizziness and headache, but younger individuals, it seems to be very well tolerated. If you see adverse events, you can always go 25% lower dose, and it tends to work well in improving the symptoms or side effects. After the Medalist trial data, which enrolled patients who are refractory to ACE or intolerant, it was moved forward, and a command trial was done, where luspatercept was compared to ACE in low-risk MDS patients upfront, who are again transfusion dependent. And this time the primary endpoint remained the same, but slightly higher transfusion dependence up to 12 weeks compared to 8 weeks in the Medalist trial. In this secondary endpoint, since we are using upfront, it was improvement in hemoglobin by 1.5 gram per deciliter. And randomization was balanced, and around 350 patients were enrolled in this study, which is an international study. And it also met its primary endpoint as well as secondary endpoint in achieving transfusion independence for 12 weeks or longer, as you can see here. And based on molecular profile, there are certain subgroup of patients who responded better than the others. As you can see here, SF3B1 mutation. Patients tend to do better even with co-mutated DM3, XL1, and TAT2, which are age-related clonal hematopoiesis. Where SF3B1 with BCOR, RAS, and STAC2, they tend to have an inferior outcome. Not only in this trial, luspatercept shown activity among individuals with ring sideroblast or SF3B1 mutation, but also shown activity among non-ring sideroblast patients as well. So it can be used in non-ring sideroblast low-risk MDS patients, provided they didn't respond initially to ESA or have a high EPO level with some success. So it's well tolerated, and the side effect profile wasn't different from the earlier trial. Recently, at ASH 2024, there's an update on this trial. And as you can see here, more than half of the enrolled patients maintain response for over a 1-year period, right? While the primary endpoint of the trial was transfusion independence for 12 weeks, but 58% of patients did maintain that transfusion independence for more than a year or so. Around 39 or 40% of patients maintain response for 1.5 years. So it has shown a long-term durability in transfusion independence for patients with low-risk MDS with high transfusion needs. So as you all know, as the current label, either of ESA in US or Reblozyl is based on transfusion needs. If individuals are requiring transfusions at least twice in the 8 weeks time span, they are eligible for these therapies. But there's always the question if we can incorporate these agents earlier in individuals who are transfusion independent, right? And anecdotally, we all do so because we are inclined to treat them based on patients who presents with complaints of fatigue and inability to perform and function the way they used to do, and then you incline to treat these patients. This trial evaluated earlier versus late induction of ESA among low risk MDS patients. This is the study schema. It's called a German study, GFM epopated study, in which they induct ESA earlier when the hemoglobin was around 9 to 10, or late induction when patients fall and require transfusion support. What they have observed, when they incorporate ESA earlier for low risk MDS patients with anemia, they did achieve a more durable response to ESA therapy compared to late induction. As you can see here, early arm has a response rate around 79% as per IWG 2018 criteria, with late arm around 50%. However, it didn't translate into improvement in progression-free survival or overall survival. Neither it has shown to improve the quality of life, which is our primary objective of inducing ESA-based therapy for MDS patients with low-risk disease. So it hasn't done that, surprisingly. So that's an important study. I thought of adding it to our discussion today, where we do incorporate these agents and we do achieve transfusion independence. The caveat for this trial, although it's a prospective study, randomized study, but the individuals of patients who are enrolled in this study were 40 in each arm. So, in summary, this trial did not delay the transfusion dependence, and however, it improves the hemoglobin and duration response. So, so it doesn't have any impact on PFS, overall survival, or quality of life features. So the next trial, which was recently presented at ASH 2024, was combining ESA like Procrit, Retacrit, Aranesp with Reblozyl in non-ring sideroblast MDS patients who failed ESA. It's a Cambola study. And there was some earlier precedents of this trial in which there is retrospective analysis where for low-risk MDS patients intolerant or refractory to ESA, Reblozyl was combined. So that was a prospective study now. And these patients are heavily pretreated with transfusion burden, high transfusion burden in 66% of patients were given pro-EPO 60,000 units weekly with 3 weekly Reblozyl. And as you can see on this heavily treated patient population, 30% of patients achieve transfusion independence after utilizing ESA with luspatercept. And a couple of patients did have a platelet and neutrophil response. There is some data from the Medalist trial was sub-published as a letter in Blood, where Reblozyl has shown to improve the neutrophil count in certain subgroup of patients. So summary, combining ESA with Reblozyl, it'll be high cost value with modest response around 30% in heavily treated patients. And there's a prospective study on a larger group of patients that are undergoing in Europe. So coming back to our case, the same patient who were initiated to Reblozyl after ESA, after initial response to Reblozyl, shows worsening cytopenia, now a little bit more leukopenic with ANC of 1. Bone marrow biopsy is still revealing low-risk MDS with normal cytogenetics. And when you incorporate IPSS-R or IPSS-M, is still low or intermediate disease. How would you treat this patient now? With lenalidomide, imetelstat, HMA, or would you take these patients to bone marrow transplant? So now I would like to share this another pivotal trial that led to FDA approval in US of this agent for managing low risk to intermediate risk MDS patient non-deletion 5q is an IMerge trial, a phase 3 trial, which used imetelstat, a telomerase inhibitor, versus placebo in transfusion-dependent non-deletion 5q low-risk MDS patient. It was 2-to-1 randomization. The primary endpoint is similar to the Medalist trial, which I shared earlier, transfusion independence for 8 weeks or more, as well as secondary endpoint was 24 weeks transfusion independence and improvement in hemoglobin. So this trial, the randomized phase 3 trial, back-to-back two trials for low-risk MDS, after a long time, we have seen a positive results where it shows to improve the outcome for this group of patients. As you can see here, the primary as well as secondary endpoint was met. Apart from that, there are some correlative studies which showed not only patients achieve the transfusion independence, but there was also decrease in variant frequency of commonly occurring somatic mutations with MDS. Some of them are high risk, such as the XL1. One thing of caution for this imetelstat study, that around 60% of patients do dose level below. Have a couple of therapies for low risk MDS when it comes to transfusion dependence and achieving transfusion independence. Apart from this, there is another approval of a drug called IDH1 inhibitor. You all are familiar with this. IDH1 inhibitors have been approved in combination with azacitidine for AML patients who are ineligible to receive intensive chemotherapy. And it's also approved for relapsed refractory AML patients who are ineligible to receive intensive chemotherapy. Unlike AML, where the IDH1 mutation occurs in around, I would say, 10% of patients, in MDS, it's rare. It only occurs in 3% of individuals. And there is some data that suggests that individuals with MDS with profound neutropenia are more likely to have IDH1 and IDH2, and I have few patients of that in that category. So there is a couple of trials done in US as well as in Europe where IDH1 inhibitor ivosidenib was incorporated in a small group of patients. Remember, it only occurs in 3% of individuals, and there was a hard to enroll significant amount of patients with IDH1 inhibitors on MDS. But having said that, in patients who have progressed on hypomethylating agent therapy, as you all know, MDS patients progressing on HMA, hypomethylating agent therapy, they tend to have a dismal outcome with median survival in the range of 6 to 9 months. In that group of patients, the overall response rate around 70% with this was achieved with very manageable toxicity profile and improvement outcome. This is the first drug, to my knowledge, which got FDA accelerated approval on only 19 patients, not a randomized study, a phase 2 study. But as we all know, relapsed refractory MDS patients ineligible to receive transplant, progressing on HMA, have a very dismal outcome. So that was a game changer that led to approval of this drug for MDS. So there are occasions in our clinical practice where we see that MDS patients who are transfusion dependent, intolerant, relapsed refractory, still maintain the low risk category when you incorporate IPSS-R or IPSS-M, and then you exhaust your resources and you think about treating them with HMA. Whenever in my clinical practice, if I consider someone to be treated for HMA, there are two things in my mind. Either first, I would like to delay the HMA therapy as long as possible, utilize all the resources available prior to that for two reasons. Because this is not a curative strategy. It may work for individuals with an average of 1 to 1.5 years, and then once patient progress on this, their outcome is dismal. Either I'm thinking about transplant, or I have a frank discussion with the patient, and I will tell them, look, we have this therapy. it may work for some time, but when it stops working, it will be very challenging to control your MDS. So we often incorporate this. But what I've seen is that 5 days decitabine dacogen or 7 days of Vardiza may be toxic for patients with MDS who commonly are elderly. And there is a study prior to this in which it's shown the modified duration of dacogen and Vidasa tends to achieve a comparable outcome to 5 or 7 days of regimen and with better tolerance and less myelosuppression. So this study, which was published in NGM Evidence a couple of years ago, showed that modified dose of Vidasa and dacogen can be given without compromising efficacy. So this is a survival curve. So this is the algorithm, updated algorithm, which is handy how to manage our patients at current in contemporary era, where the treatment based on symptoms, transient needs, molecular profile, incorporating agents sequentially before we go to HMA. Because as I told you, when we go to HMA therapy, we are thinking about transplant for eligible patient at that point in time. With this, in summary, as I mentioned, ESA, although the command trial suggests that you can use Reblozyl upfront, but if an MDS patient who doesn't have a very high EPO, ESA can still be used, and you can defer lispatercept for later lines of therapy. Imetelstat is a new induction in the treatment portfolio for low-risk MDS patients. Revlimid still stays the ideal or therapy, the first choice therapy for deletion 5q, where it has shown to have a remarkable response rate and for prolonged duration of action. Prolonged duration, IDH1 inhibitors can be used in a very small subset of patients, 3% of MDS patients, and participation in clinical trials should be encouraged for this group of patients where we have very limited resources. With this, I will thank you for listening.
Thank you so much, Dr. Dalhabada. That was wonderful. You took us through the whole journey of management of anemia in lower risk MDS. So we have our colleagues who may like to ask you some questions, and also we'll have some questions from the audience. They can put it in the chat box. I'll like to start with the first question. For using luspatercept, you go from the lower dose to the higher dose, or can we do the other way? Start the highest dose, and then after the response, try to taper the dose.
No, thank you, Dr. Agarwal. You go with 1 milligram per kilogram, and then you go up to 1.33 and 1.75. Yeah.
All right. Dr. Akanksha, your question, please. Okay, till she gets ready with her question, I have another question. If you have deletion 5q, will you start with ESA or will you go with the lenalidomide?
I would go straight to lenalidomide because, as you know, the response rate, the overall response rate of the Revlimid in deletion 5q patients is close to 50 to 60% compared to ESA or Reblozyl, with the response rate in the range of 30% or so. And where Revlimid has also a disease modifying capabilities. Having said that, it has been a challenge to give the prescribed dose of Revlimid, even in young individuals in my clinical practice. With the side effects, neutropenia and cytopenia, often you have to decrease the dose. But I will use deletion for deletion 5q. I will use Revlimid upfront rather than ESA or Reblozyl.
And when they respond beautifully to 10 mg, you taper off the doses?
Yeah, if you are having neutropenia or thrombocytopenia, you can do like a 2-week, 10 milligram instead of 3 weeks or so, or you can do 5 milligram. I have patients with 2.5 milligram in maintaining response effectively after achieving response. So I think that's a good question, and we should do that for better palatability.
And if there's a genetic response, you stop also?
That has been a challenge. I have a patient in my clinic who is on Revlimid for 18 years, and the bone marrow not showing any dysplasia, MDS fish negative, after 16 years of therapy, he stopped for a couple of years, for 2 months, and became anemic again. And I had to go back on that. So it's a individual patient case by case discussion, like if someone is willing to do that. But thankfully, he achieved a gate response again after reducing that. So hard to say yes or no, but you can try a lower dose or maybe a couple of months and preemptively go back if you see that we are losing the response.
Akanksha, are you ready with your question?
Yes, sir.
Go
So thank you for the lecture. I have one question regarding luspatercept. So when we give the injection and the patient has a suitable response, the increase in the hemoglobin, is there any data on tapering the dose or increasing, decreasing the duration of the frequency of the injection? Like instead of giving it every 3 weekly, can we increase it to 6 weeks or anything of that sort?
No, that's a very important question and very relevant to our part of the world. There is no data to my knowledge, but I've done that in individuals who are super responders,
Yes.
who not only achieve transfusion independence, but also see improvement in the hemoglobin. I've done that transiently, going every 6 weeks instead of 3 weeks for a time period. And when they go back to when I see a drop in hemoglobin, I go back to 3 weeks. So I've done that on few occasions with some success.
And is there any evidence of reducing the dose of the luspatercept? Like instead of giving, 1 mg per kg, can we reduce the dose and give the 25 milligram or something like that?
Yeah. So there is data suggesting that if you are seeing side effects, as I mentioned, especially in elderly patient population, you can go down 25%, or in super responders, you can go down as well by 25% to make it more feasible and tolerable.
Okay. Thank you.
Thank you, Akanksha. Dr. Mukesh, go ahead with your case. Unmute yourself.
Yeah, hi everyone.
Yeah.
I'd like to discuss one of my case. Old lady, around 67-year-old, presented with 9-month history of pancytopenia, requiring blood transfusion every second month. And she was other no comorbidities except hypertension, for which she was on drugs. She did a bone marrow outside, which was showing only hypercellular marrow. So we suspected MDS. We performed bone marrow. Again, bone marrow was showing hypercellular marrow, both aspiration and biopsy, no dysplasia. And we have done FISH study and NGS study also. FISH study shows only minor clone of chromosome 8 trisomy. And NGS study was normal, absolutely normal. So my question is how you'll classify this disease and how you'll approach for this patient.
Yeah, thank you. So if you see a trisomy 8, it's a no-brainer. It's MDS, right? And then you will treat around those lines. And when you use NGS, how big was your NGS panel? It was like a standard panel, a 33 gene panel, or a limited panel, NGS panel?
A standard panel only.
Yeah. So I think if you see a trisomy 8, it's an MDS, and it should be treated along those lines. If it's transfer independent, you start with the strategies to minimize transfusion needs.
Yeah, we have started on azacitidine 2 months therapy. Now her pancytopenia has improved. HB is stable around 10. Platelet has improved to 160, and TLC count has also improved to around 3,000.
Yeah. So if you started at azacitidine, as I showed you the data, you need to continue in some shape and form, because if you stop and disease goes like a changes, pathophysiology changes, it may be difficult to treat later on. The issue is that this utilizing upfront HMA is that then you have no option. You're stuck. Either you take these patients to transplant, or you continue the chemotherapy, which comes with the baggage. That's why what I try to reflect on my presentation is you try to defer the chemotherapy as long as possible, even if someone is having pancytopenia but it's manageable, let's say platelets are 70, you don't need to worry about them. Or the white cell count ANC staying above 1, you don't need to too much be concerned about that if you have low risk MDS. If someone is symptomatic from anemia, you manage that anemia and defer the chemotherapy. That is the last arsenal we have in our treatment schema up to the very end, and try to manage with other therapies prior to that.
Thanks a lot.
Thank you, Mukesh, for that lovely case. We have a question from the audience. Dr. Senbin wants to know about the role of eltrombopag or romiplastim in patients with severe thrombocytopenia due to MDS.
That's a very good question. Although there are several phase 2 studies that showing that thrombopoietin analogs do work for low risk MDS, but a couple of things you need to make sure. It's not FDA approved in US, and I get denial from the insurance companies. I do use Promacta or commonly for low risk MDS if they don't have excess blast. If you have excess blast, it can propagate the disease. Like if you have more than 5% blast, I won't use Promacta or Eltrempopag or these agents, thrombopoietin analog for MDS. But for MDS low risk with platelet count less than 30 and blast not increased, I have used it with success.
Thank you. Nishad, your question.
Yeah. Good evening, sir. That was an excellent presentation. So I am treating a patient who is a 70-year-old lady, MDS with ring sideroblast. We tried ESAs initially, but with very minimal response. Then we tried lenalidomide. She had a response for some time. And then with the availability of luspatercept, we tried luspatercept. So initially started with 1 mg per kg. She responded for a while. Then we had to step up the dose to 1.33 mg per kg. Again, she responded for a while. And then now she's on 1.75 milligram per kg of luspatercept. That's the highest dose for the last 3 months or so. She's keeping a hemoglobin of around 8 to 9. Now, how do you see any experience on such higher doses, and how do you see it in future? And if she loses the response on such high doses, what is the next line of management?
Yeah, thank you, Nishad. So you mentioned she's 70-year-old, more than 70?
70-year-old.
Yeah, so I've gone up to 1.75. In fact, for most of the time when we don't see response at a lower dose level, and if she's maintaining transfusion independence and maintaining hemoglobin 8.8 to 9, I'm assuming 70-year-old are not very active in such like in terms of work and so forth. They may be at home and managing their uh, limited chores. So I think I would continue with Sputarsec. If she failed to respond, I don't know if imetelstat is available in India or not. That could be an option. Or you can do just an IDH1 mutation screen. You may find it's only 3% of cases. Not do the whole panel, just do check for IDH1 mutation. If you find that, and if you can get an ivosidenib, that would be an option. 70-year-old, like in subcontinent, I'm from Pakistan originally, and our 70-year-old are 80-year-old in US, right? So they have very poor tolerance to intensive therapies and so forth. So depending on performance status and comorbidities and so forth, you can do HMA a 3-day duration, as I mentioned, and yeah.
Thank you. Thank you.
Yeah, thank you, sir. Thank you.
Dr. Alka, your question.
Good evening. Thank you so much for such an informative and lucid discussion about low risk MDS. I have just one or two questions. So you have shown one of the trial whether using this thing ESA in early phase or in late phase doesn't make much difference in progression-free survival or overall survival, except for some improvement in quality of life. So what is your experience? That was in the trial. What is your experience? What would you recommend, whether we should go for an early ESA institution or at a later stage?
Yeah, to be frank with you, if I see an 8 or 9 hemoglobin, though I don't see a transfusion dependence in that group of patients, I do use ESA or Reblozyl because these patients oftentimes come with complaints of fatigue, lack of energy, and decreased performance status, and so forth. I did mention that it was a small subset. They randomized 40 patients in each arm, so 80 patients. So, and I also aware that there are studies going on utilized using upfront luspatercept for transfusion-independent patients, and it's a multinational study. International study. So I do use for that group of patients, although we have seen that it doesn't improve the quality of life, neither PFS or overall survival. But I happen to use them for that group of patients for the just for the patient needs when they complain of lack of energy, fatigue, and they are more inclined to be treated for this.
Okay. So my another question is regarding dosage of HMA. You mentioned about 3 days course of HMAs. So what exactly dosage? Is it 75 milligram per meter square of ASA or 50 milligram per meter square of ASA? Can you elaborate on that?
Yeah, in the trial, and in our practice, we give azacitidine 75 milligram per meter square and dacogenotide 20 milligram per meter square, but for 3 days.
Okay. Then last question regarding MDS with fibrosis. So it's a poor prognosis subcategory. So I was just thinking whether Jakavi has been used for that category of MDS, Ruxolitinib.
Yeah. So first, we need to make sure that if MDS and fibrosis, not MDS MPN overlap. If there's MDS MPN overlap with splenomegaly, you can use Jakafi. But if you don't have splenomegaly and you have MDS and fibrosis, and you will use Jakafi, it will lead to more myelosuppression. It will make more anemia worse. It will make thrombocytopenia and neutropenia, leukopenia worse. And to give an effective dose, which is at least 10 milligram twice a day, will make patients more myelosuppressive. So unless you have splenomegaly that is contributing to cytopenia, I won't use Jakafi.
Thank you so much. Thank you so much.
Thank you, Dr. Alka. So there's a question from Dr. Christopher, and I think that opens up a big discussion. So if you have a poor prognostic NGS finding in a low risk, so-called low risk MDS, what will be the effect on your initial treatment?
Well, if you have a low risk MDS, right, and you find a P53, and even if they have deletion 5q, they may not respond to Revlimid well. If a low risk MDS with P53 with anemia, I would start talking about transplant eligible patients. I won't pursue that at that point in time. I may follow them closely and might repeat a marrow in a year's time or so to see if the disease is progressing before it's manifests phenotypically or clinically. But I'll be more vigilant in monitoring, but it won't change my algorithm much, apart from what I mentioned that the Revlimid doesn't work well with monosomies and P53 mutated MDS.
Okay, and if it is little less bad than TP53, say the question put up is ASXL1 mutation is there.
Yeah, then I will continue with the regular follow-up. And
you will not rush with azacitidine or anything of that sort.
No, I won't use it.
Young people, transplant fit, bad neutropenia, bad thrombocytopenia, will you recommend them transplant? Young people.
There's always a debate. If their IPSS error R or IPSS M is still a low or intermediate disease, I will caution about transplant because, wherever you do transplant, in a best of places, there's a 20% mortality in first year of transplant. So you always need to weigh risk versus benefit, and I would not push for that.
Dr. Vaseka, your question?
Hi, sir. Excellent presentation, sir. Is there a role of addition of azacitidine in SF3B positive MDS who is not responding to luspatercept?
Luspatercept, not responding to luspatercept, as I mentioned, hypomethylation agent therapy will always be an option for your MDS patient. It will always be an option for MDS patient, no matter what category they are. But as I mentioned, that you need to defer it as a last resort. You might use some other agents prior to that pursuing. As I mentioned, there is some limited data utilizing ESA again with luspatercept. If they're not responding to luspatercept, as I mentioned to you, this ASH updates, or you can find an IDH1 if they're mutated, you can use that, or Rytelo whenever it's available in that part of the world is will be an option. Or Revlimid for even for non-deletion 5q, there's data suggesting that it do work in 30% of cases, so that is another option. And then if you exhaust everything, then you go for HMA.
Okay. Thank you, sir.
Thank you. In a patient where erythropoietin has failed, is there any place for darbepoetin? And even to start with, is there any choice between these two agents?
Yeah. If someone is failing ESA, I'm assuming that they were high EPO, 300-400. And I don't see them working. I haven't seen it in my clinical practice, darbepoetin or those are working. If someone is not responding to Procrit. I've utilized maybe for a couple of times for some reason before we get all these tools like Reblozyl forth, but with all these available now, I haven't utilized that.
Fair enough. Any data on pomalidomide?
Pomalidomide in MDS. There was some data initially, but I am no, but I don't think so. Yeah, no.
Right. Yeah. So, any other question from the faculty here? There's nothing else in the chat box. All right. In that case, yeah, Nishad, your question.
Yes, sir. One more case actually. I'm treating a 40-year-old male who was diagnosed as MDS with excess blast 1. That was about 2.5 years back. And he was initially given HMAs with no response. He persisted to have, cytopenias, marrow with 5% blast. Then he was started on lenalidomide. Fortunately, responded to lenalidomide. And he's been on lenalidomide 10 milligrams for the last 2 years almost. So do you see, do you see that we can stop lenalidomide anytime, or should I continue it indefinitely till he's responding?
Yeah, I would suggest to continue. As long as you're responding, you may decrease the dose if there are issues with cytopenias. But I would also think about transplant. Yeah.
Yeah, so he's got a half match transplant and really transplant
Yeah.
since he has he's in remission.
Yeah, I will continue.
With that,
sorry, Nishad, I will continue Revlimid if he's responding.
Right, Nishad.
Sir, one more patient. There's a 60-year-old female who has a. Sir, can I ask one more question?
Of course, please go.
Yes, sir. I have a 60-year-old female with hypocellular MDS, but with a 5q deletion. And now this patient, now she was tried lenalidomide because she was not affording for any other treatment. So tried lenalidomide but failed. Now in a hypocellular MDS, the other option is giving ATG plus cyclosporin. Cyclosporin probably I won't be able to give because of the renal dysfunction. So what would you suggest in this patient, sir?
So hypocellular MDS, and how old is the patient?
60-year-old, sir.
60-year-old hypoplastic MDS not responding to Revlimid, and the renal dysfunction, you cannot give cyclosporin.
So she has a creatinine of around 1.8.
And
I
is
didn't
this
try.
patient,
I didn't try cyclosporin.
yeah, is this patient transfusion dependent or severely thrombocytopenic or neutropenic?
So, she's transfusion independent, severe anemia, but transfusion independent.
Yeah, so I will just
Yes,
monitor,
sir.
observe closely. I will just monitor, observe closely. And if the transfusion needs come, you can try ESA and Reblozyl and so forth. And then if these agent doesn't work, you can try HMA. Yeah, and think about transplant. But I will manage a little bit conservatively for now. If she's like low risk disease and overall doing okay, apart from the numbers being a little bit uh, borderline low.
Thank you, sir.
Thank you, Nishad. One question has come up in the chat box. Dr. Hitha wants to know, how do you interpret non-MDS defining cytogenetic abnormalities in a cytopenic patient?
Non-MDS defining cytokine abnormalities in cytopenic patients. What about the molecular profile? If there is even the molecular profile that doesn't suggest MDS related changes, I will define them as a clonal cytopenia of independent significance, CICUS, and we monitor them closely. CICUS patients, there's a variable time to progression to MDS. There's certain mutations that are high risk compared to others, such as a splicing mutation or RAS mutation. There's a tool available in which you risk score and predict the timeline they can progress to MDS. We'll monitor them closely and may initiate therapies on the lines of MDS if someone is symptomatic. Your CICUS patients with anemia, you can use ESA. With neutropenia, you can use GCSF, and so forth.
Thank you. I think that's all what we have. So, Dr. Talabada, thank you so much. You have been with us every 6 months, educating us. Our patients benefit from all this discussion, and level of understanding of this disease goes up. We will keep bothering you, and I'm sure you will keep obliging.
No, my pleasure, Dr. Agarwal. It's always lovely to interact and talk to you all.
Thank you. Okay. Amit, you have to say something?
Thank you, sir. One question Dr. Akansha has asked, actually, I was also supposed to ask regarding the role of danazole and sirolimus in the patient with Dr. Nishad just discussed the case. In CKD patient with hypoplastic MDS not responding to erythropoietin or lenalidomide. So can we use sirolimus or danazole in such patients?
Yeah, danazole has been an old drug which has been utilized for anemia, and also it, in fact, ridiculously, it was a comparator arm in momelotinib study, right, in myelofibrosis, anemia, danazole. So danazole can be used for anemia management. I don't have much experience about utilizing those agents, and so yeah.
And about sirolimus, sir?
No, sirolimus, yeah, I haven't used it, and yeah, I don't have much. Yeah, in terms of you manage these patients in terms of aplastic anemia, right? If it's a hypocellular marrow, and so I have not read the data utilizing sirolimus for those patients, but yeah, I cannot answer that question with confidence because I haven't come across the data.
Thank you, sir.
Thank you. Thank you so much. Okay. Have a wonderful day ahead. And everybody in India, have a wonderful dinner and good night.
Good night. Thank you. Bye.